everyone, so today we'll be doing two topics. The first one is normal tension glaucoma and the second one is ocular hypertension. So before doing this, we need to know that there are three things which we see in glaucoma. First is high intraocular pressure, which is the intraocular pressure greater than 21 millimeter of mercury. Second is the visual field effect, and third is the optic disc changes. So if there is visual field effect and optic disc change, but the intraocular pressure is low or it is less than 21 millimeter of mercury, it is termed as low tension glaucoma or normal tension glaucoma. But if only the intraocular pressure is constantly higher than 21 millimeter of mercury, but there are no documented visual field effect or optic disc changes, we say it as ocular hypertension. So firstly we'll see normal tension glaucoma. So definition, we know that there will be two changes but not the one change of glaucoma. We see open angle here, so we treat it as open angle glaucoma. And what is the pathogenesis? So it is thought that because of constant low perfusion in the eye, the optic nerve had become susceptible to even very less rise in intraocular pressure. And this normal tension glaucoma is associated with various conditions such as the Nod's phenomena, migraine, hypertension, uh, hypermetropia, or any other things like that. So this is all about pathogenesis. Afterwards, which visual field effect and optic disc changes do we see? These are same as what we see in primary open angle glaucoma. The difference is that in the visual field changes, the paracentral scotoma is much more deeper, steeper, and closer to the fixation point than we see in primary open angle glaucoma. And in optic disc changes, the changes are same, but the splinter hemorrhages are and the peripapillary atrophy is much more common. So treatment, here we aim to reduce the intraocular pressure even though it is less, but our aim is to reduce it so to prevent the further complication. So how much do we reduce the intraocular pressure? We reduce it to 30% of its present value. Apart from it, we give anti-glaucoma drugs. These are same as what we give for POAG. We can give the prostaglandin analogs, and here neuroprotective drugs like brimonidine is much more preferred. Apart from it, we control hypertension. So if the person is hypertensive, we advise them to take the drug like in the evening. Do not take it at night because it will lead to nocturnal hypertension and it is a major risk factor for developing glaucoma. And apart from it, we can give systemic calcium channel blockers. So this was about normal tension glaucoma. Now we'll go to ocular hypertension. So in this, there is constant increase in intraocular pressure, more than 21 mm of mercury, but there are no visual field effects or optic disc changes. If there are any symptoms, if there is any uh, any changes which are pertaining that these will cause glaucoma, we treat it and we handle it as a case of primary open angle glaucoma. So in this the changes, if present, they will be same as in primary open angle glaucoma. The risk factors are family history or posterior primary open angle glaucoma in the other eye, or any systemic disease is present, or myopia. So there are various causes for this, and the treatment is if there are some optic disc changes or visual field defect which are like arising, so we will treat it as primary open angle glaucoma. But if there are no documented defects, we will not treat it. We will just take it, check the eye of the patient annually and do perimetry, fundus examination, and all the eye examination. So that was all about ocular hypertension and normal tension glaucoma.